ரிஷி ஒரு வீடியோ எக்ஸாமினேஷன் வீடியோ பண்ணோம், நீங்கள் கண்டிப்பாக வரணும். ரிஷி, இந்த ஸ்டூடெண்ட்ஸ்க்கு நீங்கள் எல்லாமே வேறு யாரை ஹெல்ப் பண்ண போகிறா? உங்கள் பேச்சு கேட்க வேணாம், என் பேச்சாச்சும் கேளுங்க. ஓகே. Oh wow. Hey, thanks for coming for me.
I didn't come for you, sir. Please keep it as sir. Thank you. Okay, so I've got something very important to discuss with you. Recently, I saw a case in the hospital. It's a 19-year-old Indian boy. He came in with a chief complaint of blurring of vision associated with a very weird symptom.
Like what?
Guess what, doctor? It's nipple discharge.
Blurring vision, nipple discharge.
Yeah. And sorry, I forgot to say, he had a fracture. I would say it's a pathological fracture.
So, how do you know it's pathological?
Because he fell in his house, doctor. I think in the bathroom or something.
19 years old.
Yeah.
And any underlying known?
No, I don't think so, doctor. I mean, it's very relatively rare for a 19-year-old boy to just suffer from fracture from just falling in his house.
Very interesting. So I want to ask, do you think that all these symptoms are related, or are they just independent pathologies?
Just like my life, I don't think so. It's related at all. But I mean, I'm open to any clarification from.
So, have you noticed that we learned a lot about these electrolytes in preclinicals?
I mean,
but have you wondered on how its application will be handy? So, these constellations will make sense if we somehow apply the knowledge we have on electrolytes. So, it's just on calcium.
Calcium. Very interesting.
Yeah.
Would you be able to provide me with some explanation, doctor?
Okay, so this is like an overview of hypercalcemia. Read this.
Calcium.
CAL. Sorry, hypercalcemia. So what is hypercalcemia?
It's the increased calcium in the
Serum.
serum calcium. Yes.
Okay. So yeah. So calcium, as you know, it is stored in various forms in your body. But when we talk about hypercalcemia, hypocalcemia, we're talking in relation to the serum. That's what we measure, right? Let's not go into the albumin part. Let's make it very simple, just the outline. So what are the symptoms of hypercalcemia, if you can recall?
Symptoms they usually have. I mean, I know the causes of hypercalcemia. What we usually learn in medical school is one of the important causes would be multiple myeloma.
Multiple myeloma. Very good. So how many multiple myeloma cases have you seen?
Oh, that's a very good question.
Never.
Let's just say never.
Never. I've seen one probably. One of the radiologists who used to take classes from me, was from my institute, my campus. So, okay, but just one simple question. How many breast CA cases have you seen in surgical ward?
I mean, almost every
day.
Every day.
Thyroid, neck swelling?
Yeah, very common. Relatively common.
Okay, good. So, first thing, hypercalcemia, easy mnemonic to remember: bones, stones, groans, moans. What do we mean by bones? Bone pain relating to probably pathological fractures. Stones, renal stones. Makes sense, right? Hypercalcemia. And okay. Groans is abdominal pain. Moans is psychiatric related issues, depression, okay, some changes in mood, etc. So regardless of all the textbook answers that you think of for hypercalcemia, the first thing is we always overlook metastatic bone diseases. So what basically happens is, when you have a tumor which metastasizes, distant metastasis to bones, it will only have cause. Let's say you have all these pleomorphic or undifferentiated cells going to bones. So what will they do to the bones? It will leach out. They will break the bones down, increase osteoclastic activity. So when the lysis happens, calcium from the bones gets resorbed. So it's called leaching. Where will they go? They will go to the blood.
Okay.
So what are the bone tumors which will spread to the bone, which will metastasize, as you can know?
The pneumonic, particular tumors.
Pneumonic. So it's a very simple mnemonic. Very simple. Particular tumors love killing bones. P is for prostate. But when prostate tumors spread to bone, they cause a sclerotic lesion. They cause thickening. Then you have thyroid. Particularly follicular thyroid carcinoma, because it has a hematogenous spread. It spreads by blood. So particularly thyroid CAs. Okay, so if you have a case of like thyroid, CA and pathological fracture, always think about follicular thyroid carcinoma. Papillary thyroid carcinoma has the lymphatic spread. It's more commonly spread to the So probably if you have a neck swelling and lymph node enlargement, think about papillary thyroid carcinoma. You have a neck swelling and some forehead bulge or complaints of some pathological fracture, think about follicular thyroid carcinoma. Lung CA. So what are the lung CAs which will disseminate very early? Small cell, yes. Small cell carcinoma, it's okay, the neuroendocrine tumors, which disseminates very fast. Okay, that's why it's a bad prognosis. Lung, okay, maybe this might be not so important for undergraduate examination, but thyroid is very important. Prostate is important. Kidney, Gravid's tumor, very hypervascular, has a bony spread. Breast, extremely important. Breast, right? So what is the most common form of metastatic breast disease? The one that is most likely to metastasize. Okay, just remember, I don't care. Okay? Invasive ductal carcinoma. Okay, so these are the. So compared to multiple myeloma, you see breast often, you see thyroid cases common, you see renal cases. Yeah, yes. So think about various forms of. You can get complexes, various beautiful complexes. So when you take a patient, just give a brief, okay, starting introduction of the history of the presenting illness for a breast CA case that you have taken.
Okay. This patient was about 56-year-old and she was a Malay lady, presented with constitutional signs, of course, history of loss of weight, loss of appetite, presented with history of bloody discharge from the nipple. And she has got a strong history of colon cancer in the family and also breast cancer in the family.
Okay, so you're thinking about some pages related. Okay, so having that said, what else can you add in HOPI if you know about hypercalcemia? You can ask about symptoms of bones, stones, Crohn's and Mohn's, because you also want to rule out a metastatic cause. This is something most leave out. So you can, let's say for example, with all those symptoms that you mentioned, she also says that she has been undergoing counseling, psychiatric counseling for a depression she had. Would you take it as something relevant?
Yes.
Only if yes. Otherwise, you will just oversee it. Very relevant. It gives you a metastatic picture. Probably those psychiatric overtones that she's undergoing is due to hypercalcemia secondary to the metastasis. Similarly, it can come with a renal history, recent history of renal stones.
Renal stones.
Yes,
they are not urinary symptoms like hematuria.
Yes,
all those things.
Probably she was diagnosed and some intervention was done. It's not about renal stones being not uncommon. It's about you being able to link stones to metastatic disease spread whenever you see any of this breast, kidney, lung, thyroid, or prostate cases. Similarly, neck swelling and a recent femur fracture. It's important to include a femur fracture in your HOPI to stress the fact that you are trying to rule out metastatic cause. So before you do an FNAC, before you do a staging, in history itself you have a strong suggestion that this has already metastasized, right? So that's one way of looking at it. So when you talk about hypercalcemia, think about it's prioritize the cases that you're going to see. Okay? So while we go through the textbook in all its diversity, try to prioritize, try to link, apply it. You can learn about milk alkali syndrome, you can learn about multiple myeloma. While you can see hundreds of cases of breast CA, you will see an equivalent one case of multiple myeloma, maybe. So now we'll move to your case. So for that, we have to understand Men's syndrome. Have you heard?
What's that, doctor?
You would have heard.
No.
Imagine the camera is
not that, doctor.
Oh, it's black coffee.
Black coffee? Why not milk coffee, doctor?
After some age, you realize you stick to black coffee.
Nothing got to do with serum, calcium, doctor. No.
Nothing like that. So you would have heard about Men's syndrome, definitely.
Yes,
so what
multiple endocrine neoplasia.
So don't crack your head too much. Just remember it's an autosomal dominant disease. So you branch it. So what we refer to as MEN1 involves the chromosome 11, the menin gene, MENIN gene. What we refer to as MEN2 is caused by a mutation in chromosome 10 and RET oncogene, and MEN2 itself they branch into A and B. So it's just some form of tumor which affects the endocrine system. So all the organs related to endocrine function will be going a bit cuckoo, will be going haywire.
Understood.
That explains why the weird constellations came. But if you really look at the causes, you can really link everything together. So MEN1 syndrome. What are the constellations you can get? Number one is parathyroid adenoma, hyperparathyroidism. So parathyroid gland, as we know, 4 glands on the thyroid. So parathyroid glands produce parathyroid hormone, which will help to balance the serum calcium levels. Keep it simple. Okay. So if you have low calcium level, one of its function will be to break down the bones, to lyse the bones, to restore the serum calcium level. Okay. This is pituitary adenoma. Okay, so pituitary adenoma. So what happens when the pituitary gland enlarges? What are the hormones which are produced by it? Prolactin. So you will get prolactinoma. You will get ACTH.
So now it makes sense why he had a nipple discharge in the first place.
So why?
It was relatively very weird for a male patient to suffer from this kind of symptoms. But now it makes sense because of prolactinoma.
So yes, he had prolactinoma. And can you explain why he had pathological fracture? Because so he probably never had any imbalance in calcium homeostasis, but because of the parathyroid adenoma, a normal sized parathyroid gland, when it just enlarges, they go berserk. They just keep producing parathyroid.
The hormones regulate the.
So they continue hammering your bones and releasing all the calcium from the bones into your bloodstream, leaving the bones so fragile that the moment he just had a fall,
and the bilateral hemianopia can also be linked with pituitary adenoma.
Okay, why?
Because pituitary adenoma causes bilateral hemianopia.
How? Because it's located very close to the optic chiasma.
Okay.
So when the pituitary gland enlarges, it will compress on the optic chiasma, so that blurring of vision will be probably a bilateral hemianopia. And also the third manifestation will be to a pancreatic pathology. So sometimes you can get insulinoma, but these are very rare. Zollinger-Ellison syndrome.
Oh, this is where the hyperacidity situation where they can also develop peptic ulcer.
Yes, exactly. And insulinoma is when they have excessive insulin production, so they will be always in a stupor, hypoglycemic. They will be producing insulin even when the glycemic state is controlled. So it will be high insulin to glucose ratio. Okay, so that explains. So your patient basically had probably MEN syndrome, MEN1. So when he had these constellations, the parathyroid adenoma caused excessive osteoclastic activity, rendering his bones weak.
Pathological fracture.
So the moment he just had a low energy trauma, it just shattered his bone. And also he had a pituitary gland enlargement, which caused excessive secretion of prolactin hormone, which caused this nipple discharge, and that compressed the optic chiasma, causing bilateral hemianopia. And probably if you did a further history, you might have noticed some symptoms in relation to some pancreatic manifestation.
Probably could have been an upper GI bleed. Probably, I think I did not do my did not do a thorough history, but there could have been chances of upper GI bleed.
Yes. But keep in mind, this MEN syndrome is not so common, but it's very interesting to think about. You can apply it. So if someone comes with, let's say, a pathological fracture, you can always ask history to rule out this MEN syndrome, and when you present it, it will look very classy.
Definitely.
Not everyone. So you can even, when a young patient, when you don't think about any osteoporotic disease, when they just get a pathological fracture, besides these metastatic diseases, you want to definitely rule out MEN tumor. So it's almost like when you have this knowledge, you can use this to impress the examiner by putting these classy presentations in your history. So it will be a very good presentation we can think of. And MEN2A will be, what are the constellations? Parathyroid hyperplasia, same thing, hyperparathyroidism, fake chromocytoma, adrenal. Okay, adrenal.
That's where the palpitations, all these tremors.
Mainly hypertension, high BP, just high BP, and medullary thyroid carcinoma. So imagine, just like how weird that kid's presentation was. Imagine if someone presents with neck swelling and pathological fracture. So whenever you think about pathological, see, because pathological fracture is something so common.
Yes, definitely.
Right? You would have seen.
But not in the younger age.
Yes. So if someone has a fracture, you want to always think about these things. So let's say someone had neck swelling. They came in with neck swelling. While you take history to get points for your thyroid or any other possible swelling, you would also want to work on hypercalcemic symptoms. You want to rule out. So let's say you might just present to an examiner with a neck swelling. You will say that when you rule out pathological fracture, it will look weird. But when you give the point that you're trying to also think about Men's syndrome, it will look very impressive. Okay. Imagine you can relate neck swelling with just pathological fracture. Right? Neck swelling and high BP. Constant neck swelling, high BP, neck swelling. Okay. Pathological fracture and high BP. You can always link in that manner. Okay. So if someone comes with these symptoms, you can always stress upon the fact if they have hypertension or not. Okay. Men 2B will be all of this, including marfanoid features and mucosal neuroma. So when you say marfanoid, what do you understand by it?
The word oid means resemblance. So
Yes.
it means that all the signs and symptoms that you can see in Marfan syndrome.
Yes.
I think that's what.
Yes, OID. So I would really worship my pathology lecturer, Dr. Bharati, right? He made it clear. So marfanoid means the first thing is it has nothing to do with marfans. It resembles marfan. So what they mean is they will appear very tall.
Yeah.
So imagine someone with, now add these points, neck swelling, someone very tall, high BP.
Yeah.
Men's syndrome.
And we don't even have to obtain the history in this sense because marfanoid is something what we see.
Yes, you can see when someone is just walking.
Yeah, long fingers.
It's just like someone who's very exceptionally tall for their particular demography or their ethnicity. When someone very tall comes and they complain about symptoms which resemble ECS, you always want to rule out aortic dissection because Marfan syndrome, they are very susceptible to aortic dissection.
Yes.
Something like that. So in a person, you see the patient, Marfanoid symptoms, and one of these, always try to get a detailed history to rule out every point in the men syndrome constellation. So you would have studied about hyperparathyroidism, right? So what is hyperparathyroidism? So as I said, keep it simple. Many functions of parathormone. So parathyroid glands, 4 glands on the thyroid gland. So their function is to maintain calcium homeostasis. We will see as to what can potentially happen if serum calcium goes low. It could probably kill you. So that's thanks to these guys. They maintain the homeostasis. So let's say for some reason serum calcium goes low. Okay. So what will these guys do? They will release the parathyroid hormone, parathormone. So they have various functions. For example, they work on the bones. So they hammer down the bones, and from the bones they resorb the calcium, which will restore. Okay, and they will work on the intestines. Okay, they will work on the kidneys, etc. They also have effects there. So
you work on the kidneys, huh? Well, that looks like the lung, huh?
I'm not an artist, but
I think that's why you became a doctor. It's okay. Continue, sir.
I paint poetry with words actually.
Okay. I think I'd rather listen to your lecture, doctor. Please go ahead.
Okay, so we'll branch into primary, secondary, and tertiary. So the book's complicated, but it's actually very easy to understand if you know what's happening. If you always bring back to calcium. Okay. So primary hyperparathyroidism is very simple. So what do we understand by primary? The cause
is roots from the parathyroid itself. Secondary is due to another pathology from a different place, origin, something like that.
So it's native. Primary means native. Okay, so like my primary address is so that's my native address. So
native country is from India, something like that. No, I mean it's just for the sake of saying.
So meaning, just imagine these are normal sized guys, okay, chill guys, and they release the parathormone only when needed. Imagine these guys just become Hulk sized.
Just like parathyroid hyperplasia.
Yes. So one of the most common cause of parathyroid primary hyperparathyroidism is parathyroid adenoma, which comes back to men. So even when you go to hyperparathyroidism, you cannot talk about it without going back to men's syndrome.
Understood.
So imagine them just becoming big for no reason. Okay. Imagine them being big for no reason. like recently. So when you started just going to the gym, then you got all hypertrophy. And what will you do? You won't stay quiet. You will flex. You will do some flexing, and you want to do something, right? So when these guys get huge, they will naturally release more of what they produce. Yes, so even when you have a normal calcium homeostasis, you don't have hypocalcemia. Everything is normal. These guys will just keep producing parathormone, and what will they do? They will just hammer down the bones unnecessarily. Okay, so that is what will again bring back to pathological fractures. Okay, bone weakened fragile bones, pathological weakening of the bones. That is primary hyperparathyroidism. What do we mean by secondary hyperparathyroidism? So when you talk about secondary hyperparathyroidism, it is almost always linked with chronic kidney disease. Why? Because see, another factor which, so you can, where do you get your calcium from? I don't want brands, not promoting any, but general, like generic terms. Where do we get our calcium?
Milk.
Dietary. So when you don't IV, right? So when ultimately calcium goes to the intestines, you need activated vitamin D to actually absorb calcium from the intestine.
Oh, vitamin D. That's where I think the dihydroxy polycalcium. I learned this from Dr. Sri Devi's class, if I'm not mistaken.
Yes, exactly. So what you have on your skin is inactivated. So you need UV ray to activate, and there's a lot of other sequence to it. And ultimately, that vitamin D ultimately undergoes activation in the kidney because it has 1-alpha hydroxylase enzyme. This is an enzyme which ultimately activates vitamin D in a form where it can facilitate the absorption of calcium from the intestine.
Understood.
So what happens when someone has chronic kidney disease? You would lack this, right?
Yeah.
So you're not able to activate vitamin D, and you cannot absorb calcium from the intestine. So it's not about any dietary deficit. It's just that you lack the necessary transporter. You don't have the ferry to bring all the calcium to your bloodstream from the intestine.
So this is why they get hypocalcemia.
Yeah, so they will get hypocalcemia. So what happens when they get hypocalcemia? 24/7 chronic kidney disease. It's just, you're not going to have a functional kidney the next day. So it's chronic. It's already deteriorating. So you can't expect it to turn proper overnight. So what will happen? This hypocalcemia will constantly trigger these guys to produce parathormone. So what will happen when you are in a state of hypocalcemia? Yes, negative feedback mechanism. So when you're already having hypocalcemia, because you can't transport the calcium from the intestines to your stream,
increase the osteoclastic activity even more.
Yes, so this will cause lysis. But eventually what will happen is they will bring the calcium level to normal because it's already low. So this is actually physiological.
Okay.
It's not really pathological. You see, they are just doing the normal function, and that's what we refer to as secondary hyperparathyroidism. So it's hyperparathyroid because it's trying to compensate for the deficit in the serum calcium because of the CKD, which ultimately results in you not being able to absorb all the calcium that you are eating. That's second. Now, imagine the same situation over time, days after days. You keep triggering this for guys. What will keep irritating him? Keep triggering, push, give him more parathormone. What will happen to these guys eventually? Imagine you go to the gym and you just
hypoplasia.
They'll get hyperplastic. That transition, the moment they become hyperplastic, that's called tertiary hypoparathyroidism.
Oh.
So secondary is when they produce enough parathormone to keep your serum calcium normal. But imagine you trigger them to a point where they become hyperplastic, they produce more parathormone.
And what is needed?
Yes. So from normal, they increase. It causes more lysis, and eventually it causes hypercalcemia. So that is tertiary hyperparathyroidism.
Understood.
Clear. So you can link this all into one picture. Not to say that you're going to diagnose Men's syndrome tomorrow, but let's say you see a breast case, you see a pathological fracture, you see thyroid cases, You see someone with high PP and some neck swelling. You see some marfanoid features, some mucosal neuromas, some gastric issues, for example, some weird constellations like what you said, blurring of vision together with some discharge. Can always branch this into this diagram under calcium homeostasis. That's how important hypercalcemia can be. Okay, so here's this. You said you saw a case of hypocalcemia. So could you story a bit?
Yeah, the other day in the hospital, female patient post thyroidectomy. I believe day one of post thyroidectomy. It was assessed whether or not she had signs of hypocalcemia, in which carpal spasm was assessed, which is the Trojan sign, and also chopstick sign, in which the surgeon actually tapped on the patient's face and
did tragus in front of that.
Right in front of the tragus, and facial twitching could actually be elicited in the patient.
So what do you think was the cause for her hypocalcemia?
I believe post-thyroidectomy, usually the parathyroid hormones are...
Yes, exactly. So that's something very important. We saw about how parathyroid glands are important in maintaining calcium homeostasis. So this is the other polarity where you will see what happens when you remove parathyroid. So because the parathyroid glands are on the thyroid, so when you do a total thyroidectomy, you inevitably remove the parathyroid glands, and they can get into hypocalcemia. And that can happen before even the patient goes to the recovery room post-op, because half-life for parathyroid hormone is so short, it's less than 10 minutes. So they can get hypocalcemic immediately right after thyroidectomy. Okay? So that's one case in thyroidectomy. So where else can you think of cases of hypocalcemia? Rashid?
Cases. Not so sure.
So often we sort of forget the theory behind hypocalcemia because we sort of can't really link it, right? So I'm not going to go into the ward thinking of clocking a patient with hypocalcemia. It's not going to be such instant. So as I said, always merge it with something which happens common or something which can very much possibly happen. Okay. So the important, besides the symptoms, classical features of hypocalcemia, what I want to take into consideration is tetany, laryngospasm, because this can kill. Bronchospasm, laryngospasm, this can kill. I'm not worried about some skin changes so much, okay? Although they are complications. So as I said, prioritize. Okay. Next, really circumoral numbness is important for me. So whenever someone says they have some circumoral, perioral numbness, I want to immediately think about hypocalcemia. Carpopedal, exactly like what you said. It is something which really happened. You saw carpal, okay, carpal, pedal, spasm, okay, and seizures. Okay, it's not fun to see someone fitting, right? And prolonged QT interval. Simply put, I don't want some aberrant stuff in my ECG. So these are things which I want to keep in mind. So whenever I see any of these things, or whenever I think about a situation where I can anticipate hypocalcemia, I must be alarmed because I don't want someone to get into this. I don't want someone to get into this, right? So where can the situations happen? So when can you think about hypocalcemia? It doesn't need to be a chronic term. As I said, calcium is stored in your body in various forms. What we mean by hypocalcemia is specifically to the serum calcium. So there are some situations which can render the serum calcium, the existing serum calcium, useless. So in what form is it calcium ions being transported in the plasma?
Ca2+.
So what do we understand by Ca2 plus chemistry?
It leads to more ion.
So any element in its neutral state, whatever the positive charge in a proton has, it is well balanced by the negative charges which are orbiting it, right? So when we say 2 plus, it means that when it becomes an ion, it means that it lacks 2 electrons in order to keep it in a neutral balance. So probably in the last circle, 2 electrons have fled off, or they went to another element or something. Okay, that's why it exists in a calcium ion. Okay, so what happens is when you go into a state of alkalosis, meaning in your blood picture, when you take the ABG, so have you taken ABGs?
Yes, yes.
Okay, yeah. So it's painful, but whereas you take ABG, you get an alkalotic picture. Means the pH is low. What does it mean is that there's less of hydrogen. It's an acidic. It can be alkalosis means it's less of hydrogen ions which are there. Okay, hydrogen ions.
So alkalosis is pH is low or high?
High pH. Alkalosis is when the pH is high. So you are basically throwing out some acidic entities from your body. That's why you get into an alkalotic picture. So it can be, alkalosis can be always be classified into respiratory or metabolic. So respiratory, think of one situation where you throw out some acidic gas off your body. Carbon dioxide, right? So when you hyperventilate, you actually throw out all the CO2 outside, you can get into alkalosis. What happens with alkalosis? As I said, this will decrease. So about 80% of calcium is transported in this form. All of them will get unionized. So what happens when you throw out carbon dioxide? You get into an alkalotic state because CO2 is an acidic compound. So when you hyperventilate, you exhale out, okay, and you throw out excessive carbon dioxide, you get alkalotic, meaning in your picture you have less of these fellows, you have less of these guys, hydrogen. So what will happen? Remember, this calcium ion constitutes about, in the form of about 80% of your calcium is being transported in this manner, about 80. So all of them will get unionized, deionized. So they will be rendered useless because remember, for it to be functional, a large percentage of your calcium needs to be in this form. If you don't have this 2+ form, if it's not ionized in that manner, it is equivalent to getting hypocalcemia. So when you get alkalosis, this will get unionized, you will get into hypocalcemia. Right? And hypocalcemia, what are the risks? They can die from this, you can get this, you can get this, you can get things which are quite ugly.
Which means hypocalcemia is far dangerous comparatively to hypercalcemia.
Hypocalcemia, I would say it's fast, it's acute.
Okay.
Immediately, imagine if someone can just get laryngospasm. Think about the situations where you can, it may not be common for you to go into a ward and just diagnose someone of hypocalcemia, but it's very common to see hyperventilation. That's why you're wearing a white coat. In ED, you would have worked in ED, you wear a white coat, you want to draw blood. Patient sees you, they panic, can they get hyperventilation? Your friends, they undergo some stress, panic attack, they can hyperventilate, right? Where else can you hyperventilate? When you get raised ICP, raised intracranial pressure with a Cushing's triad, where you get hypertension, bradycardia, and you get hyperventilation also, you can get it there, right? Common situations, right? Let's say you're in a plane, you're flying. Someone next to you is the first time flying, and the moment the plane takes off, they start hyperventilating. And suddenly imagine while they're hyperventilating, you ask them, okay, let's say you're going to draw blood. Okay, I'm going to draw blood, and you start hyperventilating, and you suddenly complain that you have numbness over the lips. Unless you can think about this, you won't be able to relate that particular numbness immediately with hypocalcemia, and you have to. You can't be thinking about some neuropathic signs there and delaying, and you immediately want to correct the electrolyte balance because you're worrying about this laryngospasm. Imagine in a flight. So things which you need practical solution. Let's say you are flying. How can you correct this? Someone is flying for the first time and they hyperventilate. What can you do?
Breathe into a paper bag.
Yes, breathe. You can do that if you understand. So all you need to know is prevent his excessive discard of carbon dioxide. You don't want all the acid to leave his body. So rebreathe. Take a bag, they have the bag for you to vomit. Take that, ask him to rebreathe. So whatever he throws out, he inhales that acidic gas back and can restore. And you can apply this. So where else can you apply? Have you seen people wearing tight masks, face masks? Not saying that they get into acidosis, but think about it. Someone who unnecessarily wears these tight surgical masks. Imagine that. Let's say they are normal calcemic, and they keep inhaling carbon dioxide which they exhale, could they probably get into respiratory acidosis? Because once you get respiratory acidosis, your body doesn't just keep calm. It has to compensate with a possible metabolic alkalosis. It will try to balance. Okay, that's one cause. Think about some situation in you can get alkalosis due to metabolism, metabolic alkalosis. So you're throwing out, independent of respiratory gases, you're throwing out some fluid from your body which is acidic. What can you think of? Vomiting, gastric, yes, you throw out. Hydrogen, you throw out.
Pyloric stenosis in pediatric conditions.
Sorry?
Pyloric stenosis.
Exactly, you have seen. Very common, right? Olive, mass, what else? Pyloric stenosis, yes, you vomit many times. So imagine someone, child, vomiting, and suddenly they present with carpopedal spasm. Suddenly they present with some laryngospasm. So you have to anticipate, not to say that you have to always get alarmed, anticipate. So in case you see someone vomiting excessively, you anticipate that they're going to get into alkalotic picture, and you also sort of see what's happening. Okay. So let's say someone is vomiting, and what form of fluid would you want to give? It's just nothing right or wrong, but think about this. Vomiting, someone, let's say he's vomiting to a point where his blood picture is alkalotic. I would probably want to give NaCl because he has chlorine, so it can cause NaCl. That's one risk of NaCl in a normal patient is hyperchloremic metabolic acidosis. That's why Hartmann's is always preferred over NaCl. So think, when you understand the principle, you can work. You can work in a proper way. So this is about hypocalcemia.